Hi guys, my name is Isabel Garcia and today I will be talking about rheumatoid arthritis. I will hit 6 main talking points today. The first one is characteristics and history, diagnosis, treatment, some myths that are common with it, the incidence, and then women with RA that will piggyback off of the incidence. So the first one is characteristics and history. So there has been evidence that dates back to the 19th and 20th century to the Egyptian, Macedonian, and Greek times that have been shown to have lesions on these remains that we can now diagnose as rheumatoid arthritis. And then there was also an Indian text from 123 that mentions swollen, painful joints and the occasional fever. And then Guyamed the Bayou found in 1591 the first real piece of evidence, and he coined the term rheumatism to be associated with it. And then another piece of evidence that we see was a situation in the 19th century where Jacob Landry Beauvoir described painful inflammatory arthritis in 9 women, but he described it as asthenic gout because it was only in women and it involved joints and the progression of it. But we can come to later understand with Sir Alfred Garrod in 1852 when he renamed this inflammatory progression of the swollen, painful joints and fever and inflammatory side effects as rheumatoid arthritis, and he made it separate from osteoarthritis, which it is often mistaken for sometimes. So some characteristics of rheumatoid arthritis. So it is a systemic autoimmune disease where the immune system will attack its own tissue and joints, and if it's left untreated, it will have extra-articular manifestations, and it can even affect the organs such as the heart, which can be extremely dangerous. So where is it found? It's found in the synovial tissue that surrounds your joints. It is also found in tendons, ligaments, and fascia. It is a type 3 hypersensitivity response. So as we've been learning, it is an antigen-antibody complex that results in recruitment of neutrophils, and those lytic compounds from those neutrophils are then what damages the tissue. And so the effects of it are not lethal, but they can debilitate a person on their day-to-day activities, but they can still do everything they want if they treat it right, and it's not impossible to live with rheumatoid arthritis. So like I mentioned, it is inflammation of the synovial membrane that surrounds the joints. So the blue here is what we want to see, but with rheumatoid arthritis, this is what we see. And as you can also tell in the picture, there's wear and tear of the cartilage here compared to the healthy cartilage. And so since the bones are rubbing up against each other, that's why people often associate it with osteoarthritis, which is the wear and tear of joints, as compared to rheumatoid arthritis, which is your autoimmune disorder or disease where the immune system will attack the joints and the tissue. Rheumatoid arthritis does not come with age, it is just an autoimmune disease, compared to osteoarthritis, which comes with age because it is wear and tear of the bones. So seropositive and seronegative, what does this mean? So they're not really different types of RA. It's just more of if you have the definitive factor or not. So seropositive is that you are positive for the rheumatoid factor and positive for the anti-CCP. CCP stands for cyclic citrullinated peptides. So when you are seropositive, that means both are present and they are certain you have rheumatoid arthritis, and it can often be more progressive and more painful as compared to the seronegative. Just because you are seronegative doesn't mean it's any more lessened than the seropositive. It just means that you don't have these definitive factors, but you still have all these other manifestations that play roles with rheumatoid arthritis. So diagnosing it, first you have to look at the symptoms. So there is having the same symptoms on both sides. So as seen here, there is inflammation of both knees or inflammation of both ankles or toes, and it is pain and aching in various joints. There is weight loss associated stiffness, tenderness, swelling, fever, fatigue, and weakness. So to diagnose it, symptoms should be present for at least 3 months or even more before considering it as rheumatoid arthritis, just because it is such a chronic form of arthritis. So when you go to a rheumatologist, they will look at the symptoms through a physical exam, mainly looking at your joints and organs through x-rays and ultrasounds, and then they'll run a series of blood tests to check for antibodies in 4 main tests. The first one is anemia, that will check for low red blood cell count. The second, like I mentioned, is the rheumatoid factor, which is an antibody that's found in 80% of patients with rheumatoid arthritis. And then, again, like I had mentioned, is the anti-CCP, which stands for antibodies to cyclic citrullinated peptides, which is found in 60 to 70% of patients. And then they will look at the elevated erythrocyte sedimentation rate, which is just to check for the amount of inflammation in the joints. And then treatments. So as you can tell, there are many treatments for rheumatoid arthritis. The first one being non-steroidal inflammatory drugs, otherwise known as NSAIDs. These reduce pain and inflammation and are your typical over-the-counter medications, such as Advil, Motrin, Aleve, things like that. The next one is steroids, and these are in hopes that the patient will eventually wean off, and so this isn't a definitive treatment that will last forever. These are corticosteroids that reduce inflammation and pain, and they slow down the damage of joints. And then we have DMARDs, which is disease-modifying anti-rheumatic drugs. These slow the progression of RA and try to preserve the joints from further tissue damage. These are things like methotrexate, which is the most common, and then leflunomide and hydroxychloroquine. And then there are things like biological agents, which target the part of the immune system that triggers inflammation. So things like Orencia, Humira, and Kineret. These have more of a chance to develop infections and clotting of the lungs. And then there's also therapy, which is physical therapy to find new ways to do tasks or dealing with these tasks while having rheumatoid arthritis. And there are often things like assistive devices, so things like grips that you can put on metal, so it's not so much heaviness on your joints. And then the last one is surgery. So this is seen as more of a last option. This is to repair any damaged joints and relieve pain and improve the function. So this is entering a prosthesis to better function on your day-to-day activities. So some common myths associated with rheumatoid arthritis are that it only affects your joints, which is not true. Like I said earlier, if it's left untreated, it can manifest into your other organs and be very serious later on. Also, it does not come with age. Many people think that they will develop it later on in life, which it isn't discriminatory, so it can affect anyone since it is an autoimmune disease. People also say that they can't exercise because they have rheumatoid arthritis, and this is often just an excuse because it's shown that people who exercise with RA tend to have less pain compared to those who don't, and it doesn't have to be such strenuous activity. It can be anything from aerobic resistance or to aquatic exercises like that. People also exaggerate and say that it's a death sentence and they won't be able to ever do anything again, which isn't true. There are many treatments, like I mentioned. There's many things that you could do to treat it. You just have to want to treat it. And then people also say that their bones are going to diminish over time. So that goes back to what I mentioned about it being associated or it being mistaken for osteoarthritis and the wear and tear of the joints on that end. And so the incidence. So 41 out of 100,000 people are diagnosed with rheumatoid arthritis each year, women are at more of a 4% risk than men are, compared to at 2%. And women generally get it earlier in life, so in their 30s and between their 30s and 60s, while men develop it later on, so after their 60s. And so coming off of this, since women do bear children and things like that, how is it affecting them in that sense? And so pre-pregnancy planning is very important for women who do develop it earlier in life. And so they need to consult their rheumatologist and their OBGYN to find a plan that is going to fit them and their condition. You want to have it controlled 3 to 6 months. And so you also have to look at your medications. So some of those, depending on what your rheumatologist and OB say, they have to be stopped before you try to conceive. And so while pregnant, many women have also seen that their disease activity improved 60% because of their link of a hormone immune system change that protects the baby, also benefits the symptoms of RA. But postpartum, 47% have seen a flare-up because of this hormone immune system, because it helped. That's no longer there because you gave birth. And then when the baby is born, it is often important to make sure you have help from people so you're not doing everything on your own, because since you do have rheumatoid arthritis and that flare-up, it is going to be difficult. And then you also have to, whenever you're about to give birth, people often see a high disease activity during pregnancy increase the risk for preterm delivery. But rheumatoid arthritis doesn't decrease the chances of having a vaginal birth compared to a C-section, but it does increase the chance more of a preterm delivery. And then you just also have to be mindful of medications if you are trying to breastfeed. Again, still consulting rheumatologist and OBGYN. Thank you, and here are my references.